Namaskar, welcome to PK's classes. Today we will study chronotherapy in hypertension. So you can refer to our earlier classes on hypertension and antihypertensive drugs, and also you can refer to our earlier classes on chronopharmacology, where chronopharmacology deals with the effect of drugs based on their timing of administration on the circadian rhythm and how circadian rhythm influences the effects of the drug. And as you know, the blood pressure follows the circadian rhythm, and we have a peak in blood pressure at 7 p.m. in the evening. And in addition, the cortisol level is peak at 7 a.m. in the morning, and in the morning hours also the catecholamines like adrenaline increase because of the sympathetic activity, increase in sympathetic activity in the daytime. So the catecholamine level also increases, and these are the criteria based on which the chronotherapy of hypertension depends. So what is blood pressure? Blood pressure is the pressure exerted by blood on the walls of arteries, and it can be systolic or diastolic. So systolic blood pressure occurs during the contraction of heart, and during the relaxation the blood pressure exerted is diastolic blood pressure, and normal BP is 120 by 80 millimeter of mercury. So 120 is the systolic and 80 is the diastolic, and accordingly we can classify up to 129 systolic blood pressure and 84 millimeter of mercury diastolic blood pressure, it is normal. Once it is 130 to 139, high normal, and once it is 130 and above up to 159 and diastolic 90 to 99, it is called mild hypertension or grade 1 hypertension. Then systolic 160 to 179, diastolic 100 to 109, that is moderate hypertension or grade 2 hypertension. Then more than equal to 180 systolic and more than equal to 110 diastolic, that is severe hypertension or grade 3 hypertension. And isolated systolic hypertension occurs when there is only increase in systolic blood pressure but diastolic blood pressure is normal. As you know, the blood pressure is equal to cardiac output into peripheral resistance, and cardiac output is equal to heart rate into stroke volume. So blood pressure is equal to heart rate into stroke volume into peripheral resistance. So the cardiac output is dependent on the beta 1 receptor sympathetic activity. So beta 1 receptor activation increases the heart rate, increases the stroke volume, and hence there will be increase in cardiac output. So the factors which can cause salt and water retention, they can increase the blood volume and they can increase the stroke volume, so they can increase the blood pressure, and angiotensin 2 is one such factor. And all the factors which can increase the peripheral resistance can also increase the blood pressure, and vasoconstrictors increase the peripheral resistance. Calcium is one such agent and angiotensin 2 is another agent. So accordingly we can have four groups of antihypertensive drugs mainly. We can classify them as A, B, C and D. A for AC inhibitor and AT1 receptor blocker, both. AC inhibitors like ramipril, enalapril, lisinopril. AT1 receptor blockers like telmisartan, olmesartan, valsartan, losartan, beta-1 blockers like atenolol, bisoprolol, calcium channel blockers like amlodipine, cilnidipine, diuretics like hydrochlorothiazide, the thiazide diuretics can be used as antihypertensive. So these are the first line antihypertensive drugs. Besides them, the other drugs like alpha blockers, alpha 1 blockers like prazosin, doxazosin, and potassium sparing diuretics like spironolactone, they can also be used. So if we discuss the management, then the drug of first choice for people with less than 55 years will be AC inhibitor or angiotensin receptor blockers. But for people above 55 years of age, calcium channel blockers is the drug of choice. So for the first case, if AC inhibitor or angiotensin receptor blocker is not sufficient, then we can add one calcium channel blocker or a thiazide diuretic. And in the second case, if calcium channel blocker is not sufficient, then we can add AC inhibitor or AT1 receptor blocker or a thiazide diuretic. And in step 3, there can be 3 drug combinations. So here 1 drug only, here 2 drug combinations. Step 2, step 3, 3 drug combination. Then in step 4, you can add another drug, 4 drug combination, where we can add a spironolactone or one alpha blocker or beta blocker. So before discussing the chronotherapy, let us know first what happens in blood pressure. Again, hypertension can be primary or secondary. Primary, if the cause is not known, it is called primary hypertension. If the cause is known, then it is secondary hypertension. The causes can be neuronal, renal, endocrinal, or cardiac or cardiovascular. So in normal person, the normal BP dips at night. 10 to 20% drop occurs in the night in case of a normal person. In primary hypertension, there is also a night drop in BP like normal person, but in secondary hypertension, there is no drop of blood pressure in night, but there is rise of highest values at night. BP rises highest values at night in case of secondary hypertension. But in both primary and secondary hypertension, there is a morning surge in BP. In the morning, there is increase in BP, both in primary and as well as secondary hypertension. So in hypertensive patient, there is a morning surge in BP, increase in blood pressure. And in primary hypertension, morning surge in BP occurs due to increased sympathetic activity, increased cortisol, increased catecholamines in the morning. And this cortisol level increases around 7 a.m. The peak occurs around 7 a.m. in the morning. So an exaggerated morning surge is associated with increased risk of cardiovascular events, stroke, myocardial infarction, heart attack, and may lead to cardiac death. So the drugs should be preferred in the morning hours during 8 to 10 a.m. in case of primary hypertension. In case of secondary hypertension, there is morning surge in BP, but the causes may be sleep apnea, where BP elevations occur throughout the night, which is followed in the morning also. In case of kidney disease, in case of hormonal disorders that we have discussed, endocrinal, so there is morning surge in BP. So in this case, we can add an evening dose to the morning dose of antihypertensives in case of secondary hypertension, or we can apply a single evening dose in case of secondary hypertension. So management requires addressing the underlying cause. Again, the beta receptor mediated regulation of blood pressure dominates during daytime hours rather than the night time or early morning hours. So beta blockers are more effective during the daytime, not at night time in case of hypertension. Then the renin angiotensin system where the renin released from kidney acts on angiotensinogen released from liver to form angiotensin 1, and angiotensin 1 is converted to angiotensin 2 by the enzyme angiotensin converting enzyme, and angiotensin 2 acts on the AT1 receptor to produce vasoconstriction, which increases the peripheral resistance and causes aldosterone and sodium and fluid retention, causing increase in cardiac output. So both cardiac output as well as peripheral resistance can be increased by angiotensin 2 through angiotensin 1 receptor, and this increases the blood pressure. In addition, it can also has a role in inflammation, oxidative stress, fibrosis. So in this way it increases the blood pressure. So we can have two types of drugs. The one is the ACE inhibitor, and the second one is the ARB or AT1 receptor blockers. And renin-angiotensin system has also a circadian rhythm, and it is more active at night than the daytime, particularly in individuals with chronic kidney disease. CKD patients have a more active renin-angiotensin system at night. So we can have a choice now: antihypertensives, which are suitable for bedtime or nighttime dosing, ACE inhibitors, angiotensin receptor blockers, calcium channel blockers, and alpha-1 blockers like doxazocin. Then antihypertensives, which are suitable for daytime dosing, is beta blockers and diuretics. Beta blockers because beta receptor action is more during the daytime, and the diuretics because if they are taken in the night, then the patient may have to wake up in the night again and again. So diuretics should be preferred in the daytime. And as we discussed, the renin-angiotensin system is more active during night time, so ACE inhibitors and angiotensin receptor blockers are preferred in the night time. Okay. In addition, calcium channel blockers are also preferred, and alpha-1 blockers can also be used in the night time. So this is all about the chronotherapy of hypertension or chronopharmacology of antihypertensive drugs. Thank you.